Welcome to a podcast brought to you by the American Academy of Orthopaedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm pleased to let you know that we have once again just completed our annual AAOMPT conference, which took place from October 23rd to the 27th. This time around, we were in Orlando, Florida, and it was great to see everyone again. Megan Donaldson, who previewed the conference for you in episode 21, as well as her entire conference committee crew, did a spectacular job this year. While we here at the podcast enjoy bringing you interviews from research publications, beginning with this week's episode, you're going to start hearing interviews with people who presented at the annual conference. We haven't finalized all of the interviews yet, so we don't have an actual number for you regarding how many episodes this will be, but you can expect somewhere between 5 and 10 conference episodes in your feed. If you like what you hear during these episodes, then please consider checking out next year's conference, which will be held in Cleveland, Ohio from November 4th to the 8th. Also, if you want to learn more about both past and future AAOMPT events, which include the annual conferences, then please check out the Academy's web link in the show notes. Now, let's get on with the interview. Our guest today is Dr. Charles Hazle. Dr. Hazle has taught manual therapy at the University of Kentucky since 1996, first as an adjunct faculty member while still practicing as a full-time clinician, and then as a full-time faculty member. He has multiple manual therapy-related publications and has co-authored 2 textbooks on imaging. He was also the principal author of Diagnostic and Procedural Imaging in Physical Therapy Practice and the Imaging Education Manual. Dr. Hazle teaches imaging as part of the physical therapy practice for curricula in both the United States and abroad, and currently serves as the president of the Imaging Special Interest Group in the Academy of Orthopaedic Physical Therapy. Dr. Hazle, welcome to the podcast. How are you doing?
Thanks for having me, Steve.
So, we're at the conference. This is, for me, an exciting time of year. Once a year, we all get together and talk about all things orthopedic, etc. And, you showed up today, you showed up this weekend, and you're here to present on imaging as it relates to orthopedic physical therapy. In fact, the title of your session is, Do You Trust Your Hands or the Images? Now, that's a really interesting topic. I myself have a lot to say on this, but I assume you have more.
Well, this is actually a topic that I've considered for 3 or 4 years. And then back in January, I called up Bob Boyles, who, of course, is well known to most people in the Academy and is also very knowledgeable of imaging. And so I called up Bob and I said, what would you think about a breakout session on this kind of topic? And so we agreed that it is perfectly appropriate given that the trend that is occurring now in PT practice. Of course, APTA is pursuing practice authority for imaging for physical therapists. And currently there are studies underway in looking at the legal language in all U.S. jurisdictions toward this. And so, of course, in my role as president of the Imaging Special Interest Group, we have a particular interest in guiding all of this type of direction of movement.
That's spectacular, and part of what I hear when you say that is, if that's the direction the profession is moving, then we should make sure we do so in a targeted and, let's call it an appropriate way.
Right. Diagnostic imaging is both underutilized and overutilized. It's certainly cited as one of the most common sources of unnecessary expenses in healthcare. And unfortunately, I think that has been overemphasized on some occasions, and perhaps the pendulum has started to swing a little too far, that in fact, imaging can be informative. And, the interesting thing about imaging in terms of the selection to do it or not and the type of imaging is it's really informed most by the history and the clinical examination. And that's something that we in our profession do very well. And particularly when you consider, too, that the physical examination has been de-emphasized in medical school the past 30 years, there's abundant evidence of that. So I think we are ideally positioned in this profession to take the lead on this type of thing. And every time this has been studied in terms of physical therapist utilization of imaging compared to other providers, physical therapists actually look very good in terms of an appropriate use. Patient satisfaction is high, costs are minimized. Every parameter that you would want to look at, physical therapists score very well in that regard.
Based on my knowledge of the evidence, that's precisely what I would think would happen. But let's dive into that just a little bit further. So obviously there are many things we could say in response to what you just said. But let's hone in on a couple of examples that highlight why these different variables work out the way they do. For example, can you provide a couple of examples for the audience, therapeutic professionals and otherwise, that could highlight, say, a false positive or a false negative, why that imaging could be absolutely important or imperative, and then in other instances without that physical exam it could be misleading?
Right. So our presentation, what Bob and I are talking about this weekend, is imaging in reference to the spine and how that intersects with our manual examination and treatment skills. And so I'm talking about the cervical spine, Bob's talking about the thoracic and lumbar spine. And a really good example of this is the Sharp-Purser test. So the Sharp-Purser test is well known to most of us in manual therapy, and the presence of a positive test is certainly a significant finding. If we look at the studies that have evaluated the Sharp-Purser test, however, the psychometric values are all over the place. They're highly varied. And if you think of the consequences of being wrong with the decision-making associated with the Sharp-Purser test, that can be rather profound. So while a positive test may be particularly informative, how much faith do we put into a negative finding, particularly if someone is at high risk for upper cervical spine instability because of their history, because of other comorbidities they may have? Do we take that negative Sharp-Purser test as being absolute proof, or do we need to think about that more carefully? And there is suggestion that if someone is particularly at high risk, that maybe the Sharp-Purser test would not be our starting point. Maybe we really need to do a really in-depth neurological examination first, and if there's anything that suggests the potential for serious pathology, maybe imaging is actually the better route to go.
So then in the end, and not that we've explained everything, so we're at the end of an exam, but part of what you're saying is when we start to stack multiple things together, we get a better picture of what is or may be wrong with a particular patient in a particular situation.
Right. And certainly people have talked about the limitations of imaging, what it actually contributes, but we also have to keep in mind the limitations of many of our clinical examination procedures, what they can and cannot tell us. And somewhere in there is a balance of us knowing when to rely upon our hands and when we need to actually choose imaging to help us make better decisions.
This might not be precisely what you were going at there, but the example that pops into my head right now are the very large studies that come out of Canada. So, for example, the Canadian cervical spine rules. And what they showed is when they looked at large quantities of data and used certain rules, etc., clinical exam plus imaging, they were able to be more effective and efficient. So you use the image more wisely to make sure you catch the cases that need to be caught with imaging, but you don't image everybody because that's a waste of time, energy, and effort. Right.
I think we've all had that experience of seeing many patients who have had cervical spine trauma, the classic whiplash-associated disorder, and those people having had imaging, and of course, the vast majority of times, those are negative. So the Canadian C-spine rule was developed many years ago. The Nexus Low Risk rule was also developed here in the U.S. And interestingly, we go back about 10 years or maybe a little more than that, and we started to see a trend in the literature that identified that all of these predictor variables are indeed very informative, but maybe radiography is not adequate in clearing the cervical spine in the case of trauma. So there have been several studies that have in fact indicated that if someone actually meets those criteria, such as midline tenderness, significant limitations in range of motion, age over 65, focal neurological deficit, those types of things following trauma, then imaging is indicated, but it's no longer radiography as the accepted standard. It's now CT, because in the complex bony anatomy of the cervical spine, particularly at the CT junction in the upper cervical spine, there is superimposition of the bony layers, and the radiologist is actually challenged in looking at the integrity of any one of those bony layers. And so once again, if you happen to be wrong in that kind of scenario, the consequences are potentially catastrophic.
So, for example, the DENS process could be obscured by the anterior or posterior portion of the C1 vertebrae.
Exactly. The most common type of odontoid fracture in the most commonly used classification system is a horizontal line right across the base of the odontoid. So that horizontal line can be superimposed upon by the lower margin of the upper incisors and the atlas, all horizontal lines. So the radiologist really has a difficult challenge in interpreting those images on some occasions, even though you're using what was once accepted as the open mouth or odontoid view radiograph.
Which means you just took it another step or three further. It's not just you need to have a good hands-on eval and determine, hopefully through, let's call it precise or skillful clinical reasoning, whether or not you want to order imaging. You also have to know which image you want to order and then what you're looking for on that image so that you can try to make your way through all the potentially complicating variables and arrive at the conclusion that's best for your patient.
Exactly. And that's why there are a number of really good resources out there that I strongly encourage physical therapists to utilize. The American College of Radiology appropriateness criteria is one of the best resources available. It provides a great deal of information within its topics and within its variants. And if you go through all of those variants and you look at the basis for whether imaging should be done or not, and then the type of imaging, if you look at those criteria, they're all within the scope of physical therapist practice. In fact, they're all covered in common physical therapy educational curricula. So if that's the case, if those are the criteria used to determine if imaging should be done and the type of imaging, why cannot physical therapists do it just as well? So again, it still goes back to the history and clinical examination, which we can do as well or better than any other healthcare provider.
I might, especially for the manual physical therapists of this world, put better onto that just because we have more training on it. Not that we're all, as skilled as we could be. Not that I'm trying to say that all, for example, physicians aren't. But we certainly do get a lot of education and hands-on musculoskeletal examination. You could probably throw chiropractors into that pool as well. So it would make sense that we would apply those tests, those rules, and then be able to make the decision.
Right. And our ability with our manual skills as well as our other observational skills can be particularly informative for those types of decisions.
I also find in my clinical practice that sometimes it's not just the fact that I have those skills, but also I have the time to utilize them. The length of visit that I have with a patient to perform these screening maneuvers and then come to a reasonable decision it's a better length of time than your average physician.
Right. And if you look at the literature that's out there on the amount of face-to-face time a primary care physician has with patients typically, and again, this is not to speak negatively of physicians because they have to manage so many different types of scenarios, that they quite simply cannot be at a high level with a musculoskeletal exam. And so you're exactly right. With the time that we have to ask questions and to follow up on questions and to go into greater detail and to watch closely how our patients move and to put our hands on them and move them around a little bit and see how they respond. All of those things provide incredibly valuable information with our decision-making, not only with imaging, but with decision-making overall.
Yeah, I agree on that, of course, 100%. And let's be real clear and say, Some physicians do have a longer time. I've especially heard about scenarios where a specialized neurologist might even have a few hours to eval a patient, which I never do. And I know some physios, some physical therapists that will have, 15 or 20 minutes for an eval, depending on what country they work in, depending on what business they work for, what reimbursement system they work within. And I'm lucky. I have an hour every time I evaluate a patient. I feel like it's a good, healthy chunk of time that allows me to be thorough, and it's not uncommon for a patient to say, you know what, that was the most thorough eval I've had since this problem started.
Right. I think that's something that we have a luxury of doing. Now, as you mentioned, there probably are some limitations, but if we look closely at the information that we have available, we ultimately have to prioritize what are the most important examination procedures to do, and that certainly incorporates our medical screening processes, which also helps inform our decision-making toward imaging, because we ultimately have to decide, and primarily if physical therapists are truly going to be primary care providers for patients with musculoskeletal disorders, then we have to have an appropriate amount of medical screening in there and make considerations toward imaging when that is actually indicated.
I want to come back to the primary care provider point in a minute, but before we go there, and of course we can't cover the whole, or we can't cover every anatomical example head to toe, but can you give an example or two of a couple screening procedures, a couple tests that you think are particularly important for a physio, maybe something that isn't obvious, or just an example that you think is really important?
One of the easiest examples to consider would be with acute ankle injuries. Of course, the Ottawa foot and ankle rules have been out there for a long time. And if you look at those very closely, there have been dozens of studies on that. And it is an incredibly accurate tool in helping to predict who may have a fracture and who actually warrants imaging. The positive and negative likelihood ratios across all of those studies are particularly impressive. And there was actually one study done back in 2000 that looked at orthopedic surgeons and physical therapists both utilizing the Ottawa foot and ankle rules. And they were effectively equal in their utilization in an appropriate manner. So that is a common example, and of course that would very easily have a primary care type consideration. Also for your physical therapists who are working directly with athletic teams, understanding the Ottawa foot and ankle rules would certainly have direct application in that type of situation. Now, of course, one of the most overutilized ways that imaging is done is with low back pain. So certainly lumbar spine radiographs are frequently unremarkable, or they only show common anatomical variants or simple lifespan-related degenerative changes that we often have to spend a great deal of time describing to our patients, yes, you're 55 years old. These types of things are very predictable. No, those findings do not mean you're going to have pain for the rest of your life. They are equivalent, as a lot of people use the examples of, they are analogous to gray hair and wrinkles. If you get 55, you're probably going to have those too.
I feel like you just described what must be about somewhere between 20 and 90% of my clinical practice. And I use precisely that example you just brought up. And the way I usually word it is, I word it this way because it's something that patients all understand. And I say, well, your tissue's on the outside age. You know that very well because you see people every day, and you're reasonably accurate at guessing someone's age. And if your tissue's on the outside age, then of course your human tissue's on the inside age as well.
Right.
So if someone takes an X-ray or an MRI, they're not going to put your image up on a screen and then conclude, well, this 55-year-old person really looks 18. It's just not the way it works.
Right. And particularly if they have somewhere along the way gotten the message that those changes are equivalent to arthritis. Because once they hear that word, then that changes the patient's perception, and that can have real consequences in terms of their self-concept of health. So PTs also have an important role as it relates to imaging in an educational perspective. So as you described in that scenario, we must interact with our patients and reinforce to them that these types of changes are routine. If you live that long, and I frequently tell patients the only way you don't get those is to not live that long. But it is very much a factor that we have to consider in our interactions, and we really sometimes have to probe to see what our patients' understanding of the images that they may have had, what their perception of those images actually are.
Yeah, again, that's completely consistent with my clinical practice, and I spend what seems like an exorbitant amount of time taking care of that, readdressing the issues that have maybe been addressed incorrectly in the first place. And building off that point, let's go back to the conversation about being a primary care provider. Now, I happen to currently work in Canada, so I am a primary care provider. People come to me with direct access all the time, and that means on a daily basis I have to interact with imaging, no imaging. But I also get a lot of people that come to me from a physician referral. They don't need a prescription or a referral technically to see me, but it means they've gone through the system in the same way that I was familiar with when I was working in the U.S. So I'm dealing with both scenarios at the same time. And then, of course, most of us are aware that we have physical therapists in the United States who are full direct access in the armed services. They're already even ordering imaging. Can you speak for a moment about that, about how physios are already doing this and how it therefore might not be a very large step for the rest of us to join that crew?
Right. The history of the military is quite remarkable. That goes back to the mid-1970s. So we have over 4 decades of evidence that really is strongly in support of this. If you look at Canada, if you look at Australia, if you look at those practice models that physical therapists are the primary care providers in many circumstances for patients who have musculoskeletal disorders, that's where the consumer goes initially. Isn't that where we ultimately want to be here in the U.S.? We would like to have that role in our healthcare system. From that perspective, and with my involvement with the Imaging Special Interest Group, it's not that we want to just run out there and get imaging referral privileges. It's about the bigger picture. It's really about physical therapists eventually having that role as primary care providers. And to be effective as a primary care provider, we need to be able to identify when somebody does have a problem that is perhaps not going to be responsive to conservative care, or it is perhaps beyond the scope of our practice, that medical screening and the imaging go hand in hand in that regard. So we have a few states now in the U.S. Wisconsin passed specific legislation in 2016 to allow physical therapists to refer for radiography. Utah passed legislation in 2018. Physical therapists can order radiography and MRI. And then we have a number of other states, Maryland, the District of Columbia, Colorado, states like this, whose practice acts have been interpreted to be inclusive of imaging, or at least not prohibiting it. And we also have typically a common element in many state practice acts is the duty to refer. So if you look at those two factors, that we have a duty to refer when something is beyond our scope of practice, and that the Practice Act can be interpreted to possibly be inclusive of imaging, then we have the availability for physical therapists to have the legal authority to actually refer for imaging. And of course, again, APTA has undertaken a study wherein, and we've just published on the Imaging Special Interest Group web pages just a few weeks ago, we published the results of the first 24 states. The other 26 states will be available by the end of 2019 or early in 2020, where a consulting firm, a legal firm, looked at the Physical Therapist Practice Acts, other practice acts in those states that could potentially interact with the PT Practice Act, and other types of legal language to actually put out kind of a summary statement of referral for imaging in that particular jurisdiction. And that really becomes a starting point. That's a starting point for leaders in those states, in those components, to begin the conversation of where do we want to prioritize this? Do we want to actually see if we can refer now? Or does it appear that we'll actually have to take a specific legislative initiative in order to allow for referral for imaging? But I think this is the future. And again, think about this from the larger perspective of physical therapists being the primary care providers. We want to have that role in the future because, again, in every case when that too has been studied, it's very efficient and we save money and the patients are happy.
If the example you just mentioned is the starting point for this process, then of course the elephant in the room that might be the ending point, as I see it, is will or will not the insurance pay for it if a physical therapist refers directly for imaging? You know, of course, your average patient isn't going to go get an MRI without seeing a medical provider first if their insurance won't pay for it, regardless of whether or not physical therapists and physicians may be perfectly both qualified to fulfill that role. Do you have any particular knowledge about whether or not insurance companies are paying yet, or is that also something that has to be worked on?
Well, probably both are true. What we've seen with reimbursement in other areas of physical therapist practice, not only just imaging, but other areas, is it's something that's highly variable depending on your location and depending on who the insurance provider is. Now, Aaron Kyle just published a paper in August. It's an August Physical Therapy Journal, which was basically a review of their 5-year study of direct access utilization of imaging by physical therapists. And what they found is from that study, and it was in Georgetown University Hospital, so it was in the state of Maryland, they had 100% reimbursement. So we hope that is a positive sign. Now, the other part of this too is what is the insurance company's primary interest here? They are really interested in whether the imaging is truly indicated or not. So that takes us back around to things that we've already talked about. The insurance companies are also going to use the American College of Radiology appropriateness criteria. So if we're familiar with that, and that is well informed by our history taking and our clinical examination, then that makes it relatively easy to defend or to provide rationale for why we want the imaging, because the patient meets consensus-derived guidelines for imaging.
So let's just pick up on one little tidbit in there, and that is the ACR appropriateness criteria. I use them as well for clinical practice. I use them when I'm teaching. I don't know them all because I don't use them for the whole body. Are you aware, are they all publicly available?
Yes. I mean, the ACR appropriateness criteria, it is an open resource. And so I would encourage people to go to the American College of Radiology website and look around in the appropriateness criteria, because you need to be familiar with how to navigate around within those, because they have a big topic of musculoskeletal, and it has many of the common conditions that we encounter. But you also need to look at other, for example, low back pain. Where do you find low back pain? It's not in the musculoskeletal heading. It's in the neurological heading. The rationale for that being what kind of findings ultimately determine whether somebody needs imaging for low back pain. Well, very often it's neurological. And also headache, another common condition that physical therapists treat. That is under the neurological category as well. So I would encourage people to go get familiar, learn how to move around in there. And most people tend to hyper-focus on the tables that are at the front of the individual documents. But if you go beyond that and look at the end, you have a very nice distillation of the most relevant evidence in the narratives at the end that I think are particularly valuable, and people often overlook them.
I think that's extremely solid advice. It's exactly what I've done. I use them when I'm teaching topics, for example, with headache, neck pain, jaw pain. Very, very useful. I've looked them up before for the low back and some other anatomical areas. And I would just encourage people to go to their favorite search engine, type in ACR appropriateness criteria, and then whatever keyword they want, headache, back pain, ankle pain, it's definitely a great resource. An interesting and I think important part about that same conversation, meaning, the ACR criteria, I think, is the fact that if you're familiar with this type of language or this type of resource, then one of the things that you get to do and say is, I know your language, radiologist. When I call you up, when I want to talk to you, when we're going to have a conversation, it means that we're speaking the same language. So right. I think that's one of the utilities. Yes,
the language of imaging is very important to learn. That's, in fact, one of the things I strongly encourage students and novice practitioners to undertake is to become familiar with the type of terminology, the language that's used along with each type of imaging modality. Because let's say you get a radiologist report, and if it's an MRI, that could very easily be 3 or 4 pages. It can be quite lengthy. And so, once again, we talked about the patient education aspect. Well, what if the patient has brought this MRI to you on a CD, for example, they've got the images, and the report may also be on there. And if the patient has read this, they will often have questions. But being familiar with the language can often be critical in understanding the terminology of signal intensity with MRI, of echogenicity with ultrasound, with radiopacity, radiolucency, with plain radiography. All of that language is really important to become comfortable with it. And as you said, in the professional communications, so you understand how to interact with a radiologist. And they usually love it when they have someone who speaks their language, so to speak.
Just to speak to a personal example with that, I was having a conversation with an orthopedic surgeon, and we're talking about the patient, and we happened to have one of the images up in front of us, and he literally referred to the scenario as the blind leading the blind, because he wasn't really trained in reading images, but I happen to have taken classes in reading images. I'm familiar with a lot of the terminology, and I use the ABCS approach for looking at this particular radiograph, and he was relatively impressed that I could use the lingo of the radiologist. So that definitely changed the relationship that we had when we were working together, which was particularly useful because we were an orthopedic surgeon and an orthopedic physical therapist literally working across the hall from each other.
Right. Physical therapists and radiologists can become allies. And in fact, the Imaging Special Interest Group, our programming at Combined Sections meeting in Denver is entirely focused on that, of how to build alliances with radiologists. That's clearly the direction to go for the future.
So this has been a great conversation. I'm afraid, however, it's time to end it. Is there an email that we can get so that if any listeners are interested, they can get a hold of you and ask a question?
Yes, please contact me at my University of Kentucky address, crhazle00@uky.edu. And also, please become a member of the Imaging Special Interest Group. If you're a member of the Academy of Orthopaedic Physical Therapy, that is very simple to do. Just click on the link, and you can become a member of the Imaging SIG.
Spectacular. And I will link to both of those in the show notes so that people can easily find them and they don't have to struggle with perhaps getting the details correct on that. Dr. Hazle, thanks for coming out to the show, and I hope you enjoy the rest of the conference.
Thank you, Steve.
This has been a production of the American Academy of Orthopaedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.